Good afternoon. I'm Charles Shapiro, the president of the World Affairs Council of Atlanta. Welcome to today's Zoom on scaling healthcare innovations, lessons from India. Today's program is supported by CARE USA, the Atlanta Global Studies Center, and the World Affairs Councils of America, our umbrella organization. I want to give a special shout out to Bill Clifford, the CEO of the World Affairs Councils of America, and the people from the 90 plus councils across the US attending the annual WACA conference. Our council here in Atlanta is honored to be selected as one of the 3 councils of the year. To all the audience, in about 45 minutes at 12:15 Eastern time, we're going to start taking questions from the audience, so please send them to me, concise and polite questions, using the question function and the toolbar at the bottom of your Zoom screen. So again, questions, not the chat, and please don't send them anonymously. I will not ask them unless you put your name with them. Michelle Nunn has been CEO of CARE USA for the past 5 years. Michelle is spearheading an ambitious strategy to support 200 million of the world's most vulnerable people to overcome poverty and social injustice by 2030. That's a huge order, and I know that Michelle Nunn and CARE are up to that. And there's one more important fact about Michelle Nunn that you need to know, and that is that yesterday was her birthday. So happy birthday, Michelle. I'm going to turn this over to you, and Michelle is going to moderate our program.
Thank you. Thank you so much, Charles. And to our panel and to our participants in the conversation today, I'm really thrilled to be a part of this program with the World Affairs Council of America National Conference. We're very proud of our partnership with the World Affairs Council in Atlanta. And by the way, huge congratulations on being selected as one of the councils of the year, well deserved. I think we have such a timely conversation today. When you think about the importance of global health to strengthening our national and global security, we have certainly seen the extraordinary nature of that in such a material way in this 2020. And so I think we have a really marvelous panel to talk about successful insights from health initiatives that have been scaled in India, but that also, I think, teach us a lot about the work ahead for us globally. So I'm going to introduce them very quickly, and they have long and distinguished resumes and bios, but Dr. Casey George, who is the Joint Director, Women Development with National Institute of Public Cooperation and Child Development with the Ministry of Women and Child Development with the Government of India. And Dr. George is leading, planning, training, and monitoring and supervising a huge number of flagship programs in the Institute. And so we're eager to hear more from him. Dr. Seema Handu, who is the country director for PRONTO International in India. She has a focus on building capacity of local government staff, really nurses and doctors working in the public health system. And then finally, we have Dr. Sunil Babu, who is what we call chief of party, which means kind of leading the work of CARE in our Bihar technical support program, which is in support of the government and the larger healthcare system. So Dr. Babu has been with us for more than 20 years and has been an extraordinary architect of this work. So, just to again set the context, national security and global health are really inexorably intertwined, and we, again, may not have always appreciated that in the way that we do today, but it's very timely, given that we're in the middle of a pandemic, to see and talk about how our national security relies on reimagining and taking bold action to really ensure our global public health infrastructure and our healthy populations. So if you think about health diplomacy, it requires that we use innovation to help scale our work and to support communities and to address healthcare challenges. And 2, that we constantly test and that we're generating new ideas as solutions to some of the biggest problems in development and diplomacy. And at CARE, we do this in all areas of our work, from food security to education to healthcare. And the third thing I would just lift up is developing technologies to prevent and mitigate disease, and that help also design new solutions alongside multi-sector partners, which is who we're going to hear from today, which can and is making a difference in saving lives. So, our panelists are uniquely equipped to tell us about health innovation. They are experts in particular about how that's being applied in the state of Bihar, India, and in particular how it is materially improving the quality of maternal and newborn and child health in an enormously populous state. So I think the work in Bihar can be translated to other states and countries, frankly. And so we're very interested in hearing about how we can enable new approaches for sustainably improving our health diplomacy and global security. So before we get started with the panel, I've asked Madhu Deshmukh to take a global picture. Madhu is a colleague of mine at CARE. She was the first chief of party, so one of the originators in the partnership in Bihar, and she's now our overall vice president of programs, and just wanted her to sort of set the stage for what the work in Bihar looks like that we're going to go deeper on with the panelists. So Madhu, I'll pass it to you.
Sure. Thank you so much, Michelle. And I'm really delighted to join all of you today and happy to share a bit of a background on Bihar, India, and CARE's work with the partners to set the context. Bihar is one of the largest and most densely populated states in India, with a population of over 100 million plus people. And for years, the state has had limited resources and infrastructure that has impacted its healthcare system. And as a result, Bihar has had some of the poorest indicators related to maternal and newborn health. In addition to that, extreme poverty, gender, and social inequality, including low literacy rates, have further compounded Bihar's poor health outcomes. So in 2010, with support from the Bill and Melinda Gates Foundation, and along with the government of Bihar, CARE began its work to improve the maternal and newborn care and strengthen the health systems and to support the government of Bihar. The program essentially works at three levels. The first is improving quality of care at the health facility level. The second is strengthening the frontline health workers and the outreach to the community level. And third is supporting government of Bihar at the policy, leadership, and the systems level. What began as an initial pilot in 8 districts in 2010, which included some of the innovations that were rigorously tested and scaled up, has now quickly moved to all of the 38 districts in Bihar, as well as other geographies in India, and we will hear more from our panelists. After 10 years of working in Bihar, we have seen significant impact, and that's been really humbling, and very, very proud of the work that has gone on with government of Bihar and all the partners. The program has contributed to state-level impact in the areas of maternal and infant mortality. For example, the maternal mortality ratio fell by nearly half, from 312 to 165 maternal deaths per 100,000 live births between 2005 and 2018. We also know that there were nearly 20,000 fewer newborn deaths in 2016 than in 2011. And these are just some of the just some of the brief statistics to show the kind of impact this program has made in Bihar. And so CARE has continued to work with the government and with other partners such as PRONTO to test and implement innovations to improve the health outcomes and strengthen the health systems. I'm really excited to hear from our distinguished panelists more on some of and outlining some of these aspects. So with that, over to you, Michelle. Thank you.
Thanks, Madhu. So I think you can see why we think that this is a model that we want to share more information about how this work is has really advanced and accelerated the kind of outcomes that Madhu shared around maternal and newborn and child health in the state of Bihar. And so maybe I'll start with you, Dr. George. Should you lead the India's National Institute of Public Cooperation and Child Development. You have a strong focus on women and children. Maybe you can just tell us a bit about how innovation and scale is a key part of the work, and how government in particular is supporting the design and culture for innovation, and also this sustainability. I mean, you're looking at 110 million people. And so I think we want to take those lessons and think about what does that mean for us from a global public health infrastructure and some systems perspective.
Thank you, and good afternoon to all of you and the viewers, especially people us from India. All that I'm going to talk during this 4 or 5 minutes on innovations as a strategy that we took up to give capacity building to the people to improve or for the development of any program, for the success of any program. What kind of innovations we could go ahead. And all that I speak is my personal observations and views, which I earned over a period of, say, like 30 years of working in the area of training. So my experience on innovations goes, number one, there was no innovative training for us in the initial stages. We talked about innovations somewhere in the 80s. We started talking about innovation. What could be this innovative training? We heard something like, of late we were in pandemic, for the last 8 months, we said, how do we train the focal workers, or we call them Anganwadi workers here, on growth monitoring? A question came, how do you weigh the child, who is a newly born child? Now, how do you teach that woman or the worker to weigh that child? So, in the general way of training, physical training, we used to teach them with a weighing machine. Take the weight, plot them on the card, then put it on the graph and tell them where the child belongs to, curve, join all the curve, and then tell them what is the growth of the child. So that used to be the status. Now we said, during the pandemic, how do we go about? How do I teach the children who are there in front of me, or the Anganwadi workers who are there? How do you teach? It has become a big problem. So there were issues on communicating with them, because we have about 15 official languages here, or we are talking in different dialect here, which all need to be addressed at one place. And the literacy of the persons who are there at the grassroots level to learn and understand the precise concept on the developmental or the process of making our children develop. These are all became very important to us. Now, these kind of innovative approaches came in our mind long back, where we talked about sandwich training program in the area of development of children. So we said we'll do some kind of sandwich training program, because we came out with a project which was called Odisha. So it came as a sandwich training program. Because of the after the sandwich training program, we had the World Bank coming up, and we came out with various other training programs. Then after all this, at the end of the day, today we have had also the CAS training, computer software application training, which gave a wider strategy. For example, we had about 11 registers were there to note the various aspects in an Anganwadi center, which was discussed also with various organizations. Care was one of the most supportive in those times, as Madhu was talking about the Bihar experience. So they came out with a software where 8.9 kilos, that 11 registers that weighed, were brought out to 170 grams. There is a small software which anybody could carry. So removing the weight and leverage, what do we call that? That word was completely taken into account. And Anganwadi worker was digital literacy that our Prime Minister was propagating for the last so many years, that came into be part of the integral learning aspect of any Anganwadi worker. So that was one of the innovative measures. We never thought an Anganwadi worker would be able to jot down the weight of the child or tell all those 11 aspects of this thing in the computer. But now we are confident and they ask us and they themselves are trained on it. And we give them this capacity building on a virtual mode now. We did it precisely for the state of Tripura. And it was very interesting to listen to and how they accepted the concept of understanding the whole view on the computer, which was very distant dream for them, which they could do. So those kind of innovative approaches we started with. We for the last so many years, what we have been doing during this 8 months, we did about 605 virtual training. Now 605 virtual training I am counting till yesterday, and in which we have trained about 77,519 people at various places. We do the trainings in a regular training. What we do, like we have a few schemes like Beti Bajao, Beti Padhao, BBBP, or one-stop center we have, where all the women who are affected comes under one center and then we give them the shelter. We have Swadhar, we have acts and legislations for the women. We have also continued e-learning courses on infant IYCF, and we also have integrated child development. Then we talk about combating gender-based violence. Of late, we have been concentrating on psychosocial care and counseling of caregivers for the distressed women. We talked about strengthening leadership, child adolescence, and developing emotional resilience among children, development delays. These all are part and parcel of focusing on the integrated child development services, or these days we call them Anganwadi services under umbrella ICDS scheme. We also, under that scheme, we look at the adolescents on their mental health. One of the focus area that we talk in every Anganwadi center. We talk about their menstrual hygiene and career talk. So all those clients or all those people who are in need of a precise training, we do take them into account. Now, in per se, with the child protection, like International Child Rights Convention based at 1992, what we are doing, we have developed a protection mechanism in our country. We got JJ Act, Juvenile Justice Act, which we had initiated in 2000. Later on in 2015, we have revised the thing, and we have cyber safety, child sexual abuse, child rights, and we also talk about child trafficking. So all these are the training programs that I discussed just now. How many we have? 77 people, 1,000 people we could gather, and we could give them at various intervals in various groups and various training programs. Now the issue is that whether we do cultivate a culture of innovation. Yes, we do that. We have a culture of innovation. Second point is whether we adapt to the innovations implemented by the partner. We do. For example, early 90s, if I recall, when the self-help group program came up, we innovated, or we rather developed Grameen Bank policy, or we developed Pallikarma Sahayak Society, or ASHA, or those were the organizations which started with collecting a group of 10 people and giving them economic support by self-help group and all that. That same program was accepted by us, and we started a program which was called Integrated Rural Women's Development. So we did that. So Shakti Pariyojana, we had it in our group. So we had the capacity. Always our government was cooperative in adopting which was better for the benefit of the grassroots women. So that is there. So partnering with organizations was one of the key agenda of every people who are working in the sector. And a word which was used early in 80s, we came out with the word convergence. And the convergence meant we integrate, or we talk to, and we converge with various other sectors with a precise objective. Now, what objective is very clear. Our objective is to bring the child to its developmental status, that every child is important for us. No child should be left out. So I need to develop the child, whether it is physical, social, emotional, or psychosocial development. All these are taken into account by our organization. So each child is taken from the very beginning of its birth, even at the level when the child is in the pregnancy stage, with the mother. From there on, we take care of the child, as rightly pointed out by Madhu, on the infant mortality rate coming down, or the mother's MMR which is coming down. So there is a great contribution by using the word convergence with various other departments or various other organizations or various other partnering good experienced organizations like CARE and all that. Because of late CAS training, they have been doing a lot for us. We were there and they were supporting us also in the past and at various intervals. And we were also part and parcel of taking them into. Then designing the program. We were always using a what do you call corporate, what do you call a partnership mode, or rather participatory mode. We invite, before a program is designed, there is always a workshop held. For example, we want to innovate something on the development or identification of mental illness among the children at a very early age in the Anganwadi center. We have a partnership with the organization. We call them together. We have brainwashing, try to understand the status. How do we go about? So there we start with, and then we identify how this training can be given to them. So then we realize what is our target, what could be the strategy, who could be the resource persons, what could be the qualification of a resource person, how many days of training program would be good enough, or how many days of refresher training would be required for them. And once you complete this training, how do we go about? For example, during the last 3 or 4 years, we did a program called the Program for Empowering Women. Like all the elected women representatives of the country, whether they are ward sarpanches or the ward members, we strategized a program for them. It is a 3 days program for them because they don't have time. They have to come from the villages, and the precise strategy was adopted. In the first and second phase, we trained around 33,000 of such elected women representatives across the country in 2 years. Now, this was a strategy which was one very clear, precisely in our mind. But before introducing that topic, we have had the international, national, and the local organizations coming together with us. We understand how effectively we can target, how effectively we can tell, or how effectively we can train these women who are partially or to some extent not literate enough to read and write and understand what I say. So coming down to the level, using the techniques of teaching them through pictorial graph or pictorial booklet, or if I want to make them learn on the laws that is existing for them, or all the legal laws that is existing for them, we teach them through the pictorial graphs or pictorial books or charts that is prepared, or the posters that we prepare. That is how we went on, and it went on a very at a very great success, or we were happy with the output of training these 33,000 women. And now we are going to the next phase during this one, and we will be successful in that as well, we are sure. We have a precise focus on the pregnant women and the breastfeeding mothers and their newborns, and we also talk about children below 5 years especially, and the adolescents, as I told you. And in CAS, we had the components like convergence. As I told you, it is not single-handedly taken out by ourselves, but it is with the convergence that we are talking for all. So, and the third point is we also look at today on the behavioral change or the CB or IEC advocacy that we talk about, or even on adoption centers that we have in India, like CARA. Then we also have a grievance redressal cell there. And one of the most important component is the training capacity building cell that is pointed out at the level of training the workers or the helpers in our country.
Dr.
And the
George,
therd point is whether this.
Dr. George, I just wanted to, sorry, I just want to make sure that we can go all the way around, and so maybe we'll just one more point, and then we'll keep going.
Yeah. Shall I make one more point and stop there?
Yeah, that would be great.
Yeah.
Maybe just a quick point. Yes.
Yeah, sure. Then how do we initiate adapting these innovations? We do adapt, I said. If something that is found good enough, we do adapt, and we keep that sustainability of that innovation throughout our training programs, which we have been practicing for the last 30 years as a trainer. As a national level trainer, I do practice that wherever I find something which is interesting, where it's innovative, where I can achieve my target of reaching the people with the same tempo, then I do keep that target in my mind. I keep that strategy along with me. Thank you so much for the brief introduction of the innovative training techniques that we have used. And I'm sure it will be useful to you. I'll be available for the questions thereafter. Thank you.
Perfect. Thank you so much. That's wonderful. Sunil, I'm going to turn to you to talk a little bit. We've heard an eloquent articulation of some of the ways that innovation and sustainability are taken into account, scaling, because the level of scale here is really quite extraordinary. So maybe you can talk a little bit about the work that we've done with what we call the Bihar Technical Support Program, which is a way of taking a partnership that CARE is providing in terms of support and again, partnership with the government, and how you've engaged scale, innovation, impact in that would be really helpful. And maybe just to articulate too, because I think it's sometimes hard for an audience like ours to get their arms around the scale. How many, for instance, community health workers are we talking about in the state of Bihar? Dr. George alluded to the engagement of community health workers around digital approaches that seemed unimaginable even just a few years ago, but now are very much integrated and incorporated. It would be great to get a sense of that from your remarks.
Yeah, should I give it now or I'll give it at the end of it?
Oh yeah, no, I was going to call upon Sunil to start, and then maybe we'll come back. And yes, we would love to come back to you for that. Perfect.
Sure.
Thanks, Michelle. Being innovative to identifying innovative solutions and taking them to scale has been identified a recognized role for development organizations like us. And in the Bihar program, where we have a mandate to impact on maternal child health indicators for a population of almost 100 million, 100 plus million population, which is being served by almost 200,000 frontline health workers. So that is the scale at which we have been attempting to impact. But when usually, in order to build this, so far the kind of culture of innovations and scaling, how it got built into this Bihar program, both for the technical support work that we do, as well as the government whom we provide the technical support to. Unlike several other projects where I have been associated with, usually the innovation, developing an innovation has been starting from identifying a challenge or a barrier to achieve the required impact. So looking at the context where we are operating, what is a large scale prevailing problem or an issue, and finding innovative solutions for such problem is what was attempted. And all along, work with the agency or the people who are going to take an innovation to scale, keep them all the time involved, is something that has been key to promote that ability to go to scale. The example that we were talking about, if I could just use the same example, which was way back in 2011-12, that's when this two frontline workers cater to the same set of population with similar kind of interventions, maternal child health interventions that they have to deliver. Both of them have different kinds of metrics, different kinds of reporting systems, etc. So in order to make that synergy, bring synergy between what they do, innovative use of mobile technology, using ICT to enable their work to be easier, and at the same time all the data that gets captured, so that service utilization, coverages, behavior change, communication, etc., gets tracked at all levels. So that's when this particular innovation of common application software, which Dr. George referred to, that got evolved. And then all along with that, there were several other innovations also that were tried to solve problem. All along, that has been something that is built into the culture of the program here. And even at the national level also, in the Ministry of Health and Family Welfare, there is this constant push to be innovative, to come up with innovative solutions which get exchanged between the states, and states are encouraged to, states means the state governments are encouraged to adopt from each other to solve common set of problems. So all along in the CARES program in Bihar, the Bihar Technical Support Program, for every innovation that has been tried, there has been a mindset of constantly looking for whether the intensity of implementation has been adequate or not, and whether an evaluation shows that the intended impact is getting achieved or not. So that kind of a constant measurement of how we have been impactful in an innovation and articulating that is something that has all the time enabled to reach to scale. Like recent times also, this is like an ongoing phenomenon. Recent times also, like in order to address a particular problem of delivering health supplies to the last mile, an innovative way to bundling it with vaccine delivery that is going on was tried. Its effectiveness was tested up to the level of seeing whether sending such supplies from central stores to village level, whether it is increasing or not increasing the final availability of the products to the mothers and children. So with that in mind, the effectiveness of innovation was tested, and now that has gone to scale all across the state. In the same way, like one particular specific innovation that I would like to mention, which was developed and taken to scale in Bihar, is like around 2010, a large number of mothers started coming to health centers for deliveries. Earlier, it was mostly deliveries were happening in homes, but suddenly there was an increase, and a very rapidly increasing numbers were coming to hospitals. But the nurses and especially the nurses who are attending to these deliveries were not skilled to handle that level of load, and the institution was not yet set up to take on that kind of load. So an innovative approach of adopting mobile nurse mentors, clinical mentoring, who go from facility to facility and create a system uh, in each of the environment to deliver appropriate services, was tried out, which built a number of clinical skills for these people using externally brought in nurses to train, and also adopted simulation as a method for teaching, making the skill enhancement possible. That has been measured in a consistent manner, and delivery outcomes, practices, clinical practices during the mentoring period were all tracked all along through third-party evaluations, and that has been adopted for scale up all across the state. And I think we need a lot more to learn from the simulation experiences that we have gained. Those are some points I have.
Thank you so much, Sunil. It's pretty, I think, important to remember how you all are integrating technology at such a scale. So imagine that you have community health workers, hundreds of thousands of community health workers who are now equipped with the devices and the capacity to take information from their visits to families and to have that be integrated into a centralized data system that enables the kind of continued evaluation, monitoring, and pivoting. And that, again, was something that people didn't even necessarily think was possible. Would these community health workers be able to utilize this new technology? Would they be able to track this data? And how would it then be evaluated? So I just think it's important to step back and say how important it is to consider, again, the combination of these innovative thinking, technology, thinking at scale, and as you said, some of the simulation, how you're using people and technology to reach new thresholds of impact. So I want to turn to Dr. Handu and ask you to maybe elaborate a little bit about the work that you all have been doing to reach frontline workers, maybe just to expand upon some of the themes that have been shared and the work that you all are doing to design innovative models at scale.
Thank you, Michelle, and good afternoon, everyone. So before I get into the program, exactly what we did with CARE, I just want to give you a brief introduction to PRONTO. PRONTO is actually a US-based NGO, which is headquartered in Seattle. And our goal is to optimize care during birth. We envision birth as a safe and respectful experience for all mothers, babies, and healthcare providers. And Pronto was actually started about a decade ago in Mexico in response to a need for effective training of nurses who are working in the maternity labor rooms. And our first innovation right there was to change how and where the training was conducted. We moved away from training in a regular classroom setting to training in the labor room, which is exactly the same setting where the providers will be performing their jobs and using the same supplies that would be available to them in their own labor rooms. So that training proved to be very effective, and thus what began as a modular training now has grown over the last decade and into a portfolio of programs and trainings, and now providing a mix of in-person and now virtual trainings also in 14 countries. But each one is responsive to the local context, which is really important here. Basically the four more main pillars of any Pronto training are actually, first is this realistic simulation that Dr. Sunil Babu also mentioned. We use simulation training to create almost realistic emergency situations. And then we have video guided debriefing on this. Then we also have the teamwork and communication activities to improve individual and team performance. And we do knowledge reviews to improve the clinical skills of the healthcare providers. And then there are team and facility assessments that can feed back into any accountability program, whether they're a facility specific program or whether they're government specific program, or in our case, we also use it to inform later our more training programs. And we have compelling evidence from Mexico, Kenya, Uganda, and India in Bihar that this model improves teamwork, use of evidence-based practices, provider confidence, respectful maternity care, and clinical outcomes. So, about 6 years ago through an incidental meeting at one of the international conferences, it became clear that the gap between knowledge and practice that we had seen in Mexico was also happening in India and actually in many other countries. And that Pronto simulation technology could be an answer to this widespread problem. And so that was 6 years ago. Upon CARE's invitation, we came to India, to Bihar. And I want to clarify here that the way Pronto works in India is through a collaboration of actually 3 entities, which is University of California, San Francisco, University of Utah, and Pronto. And we call it linked. And what we bring together as a team includes innovation, implementation, and discovery or research. So in order to continue to innovate, implement, and discover, we work with, with best of the best at these institutions as well as other partners. For example, in India, in Bihar, for the nurse mentoring program that Dr. Sunil Babu talked about, we collaborate with our in-country partner, CARE India. So CARE and Linked work very closely together in implementing this large Amanat program. So in the large Amanat program, simulation is one piece of the training, and there are other components of the training that are conducted by CARE. About scale, we talk about scalability. I mean, when you work in India, the numbers are so huge that you're always scaling solutions, right? India being the second most populous country. And as you've already heard, Bihar alone is 100 million people. So when we started 6 years ago, we were not sure if we would be able to scale to that level because we hadn't done that before yet. But our first program, it involved training nurse mentors to become simulation facilitators who then go in the field and train the other nurses who are working in the healthcare facilities. So over a period of 3 years, we trained 120 mentors who then trained about 2,500 nurses in 320 facilities. And this program was very successful, and the use of evidence-based practices improved dramatically. So we showed a 37% overall improvement in intrapartum practice scores and 26% improvement in newborn practice scores. Then our next challenge was to see, okay, if this Amanat program, if this is scaled to 300 plus facilities, can we take it to all the facilities in Bihar, in all 38 districts? And also, can we make it sustainable, which meant, can we make the government nurse staff as mentors? Until now, we had nurses on contract who were the mentors, but now we wanted to make the staff nurses as mentors. So that was a challenge that we decided to take along with CARE and us together. So that program became Amanat Jyoti. And in that, we basically, in order to reach the scales that we were talking about, we had to add another layer of supervisors in the mix. So then we trained a group of supervisors who then trained the nurse mentors, who then trained the nurses. So now we had a three-tier system instead of the two-tier system that we were working with before. So that was very challenging. And we were not sure the government staff nurses who we were going to train as mentors, were they able to, will they step up? We were not sure about that. But then along with CARE, we worked very closely to plan the whole implementation strategy. We had to add several steps in between the program where we would monitor the fidelity to our training methodology to make sure that the core principles were passed on appropriately. And we made use of our video recording and debriefing technology to help us do that. So in the 2 years, we trained 60 supervisors who trained 700 government staff nurse mentors in 350 facilities and who then trained 3,000 nursing staff. This program was quite successful. And now we are actually, we were surprised that the government nurses stepped up and they became, quite decent nurse mentors, I would say. And now we are actually expanding this program to cover all facilities, about 540 facilities in 38 districts of Bihar. So this is all about the scale. Now, we also talked about collaborations and partnerships. So PRONTO as such is always committed to being integrated and supporting other capacity strengthening efforts rather than being a siloed standalone player. And that's actually is a challenge because the audience does not really know who PRONTO is because we are always integrated within a larger program. For example, in Bihar, we are Amanat, right? And in Uttar Pradesh, we are part of their nurse mentor program. In Kenya, we are part of the preterm birth initiative program and so on. So so many people, the audience, the people who are actually looking at the program from the outside may not know who PRONTO is because PRONTO is always so well integrated into the larger program. At the same time, our goal is also to make sure that our programs are sustainable, ensuring that the skills are in country and are controlled by the local government. So that when we leave the program or when we leave the state or wherever country we are in, that the program still goes on and the governments are able to continue in a sustainable manner. And so for that, actually, we are now using quite a few virtual training components as our next innovation to be scalable and sustainable. So we have virtual modules and sustained engagement from the platforms that people can access and engage in their own time from their own place. That's the way to spread the innovation. One of the latest examples for innovation is we have what we call Super Divya. It's a series of actually superhero-based virtual education modules, which are used to support, engage, and educate the nurses to become simulation facilitators. And that leads to increased engagement and community of practice for trained simulation educators. So this is just one example, but more and more, especially during the pandemic also, we actually quickly evolved and made our training from completely in-person training to, to a hybrid, a virtual and an in-person training. So, we are more and more going virtual, and it will help us be scalable, help us be sustainable, and also be able to, work during the times of pandemic or any such things that might happen. So with that, I hope we can get into more details during Q&A if we have time. So I would encourage any questions at this time. Thank you.
Wonderful. Thank you so much. So we have a rich, I think, tapestry to build upon here. And I would just make a few comments and then I'll pass it to you, Charles. I mean, some of the things that I've heard around how do we invest in both health innovation and for our sort of global security, recognizing that that no community is safe ultimately until all communities are safe. And how are we investing in prevention and also treatment and some of the foundational elements. I heard themes of there's cross-border. In other words, Seema, you talked about the work that started in Mexico that's now having a huge impact in Bihar. I heard the importance of aspiration, but a number of you talked about the fact that at first you didn't know how you would do this, right? How would you reach so many people? But the confidence of saying, this is where we're going, and holding that aspiration, I think is really important. Obviously, resources, we're going to have to invest in new ways for resources to undergird this health systems and health security. And I think it's arguable that we have not invested sufficiently around the world, truly. I've heard themes of cross-sector that we really have to work. You talked about academic institutions, we talked about civil society, we've talked about obviously government, because that is where it's ultimately going to be sustainable, and that we can't sustain this without that kind of real cross-sector collaboration. You all talked about technology, how important that is, but in particular, how we then use data to measure and evaluate our work, and then to create change and to pivot as a result. And then the last theme I heard was around leadership. You all talked a lot about training, and how are we investing in our leaders, and how are we believing in what's possible for everybody from the frontline community health worker to our nurses and doctors to our public health system leaders. How are we going to invest in them? So I think you all have created a model that is something that we can take a lot of lessons for, and hopefully apply in bigger and broader macro ways as we go forward. And Charles, I know there's some good questions that are coming on the chat, and so I'll turn it over to you to go a little bit deeper.
Yeah, there's some great questions here. The first one I want to ask is actually a challenge for you, Michelle, I think. And this is from Saukat Anwar in Worcester, Massachusetts World Affairs Council, whom I'm guessing is originally from Bangladesh. And he says, how can we learn more about this, and how can we apply this program to other countries like Bangladesh?
Well, it's interesting, and I might turn to Madhu, because we have been working with a kind of team to think about how we can replicate this model by sharing it, basically, by other governments and civil society partnerships taking it up. And Bangladesh is one of the countries that we've been working with, as well as some of the countries in Africa. So we would love your ideas for how we can share this message. And again, I think one of the keys to our global health security is, how do we take what's working and how do we replicate it in places around the world? And so Madhu, I don't know if you want to expand upon that.
No, I think you said it, Michelle. The team here is working with Sunil Babu and the team in India to see how best can we develop certain products along with the partners. So to Seema, I think with Pronto, how do you bring out products that talk about the work on nurse mentoring, so that those materials are available on the website. People can connect, can learn more, connect through those websites, and also working with Care Bangladesh and Government of Bangladesh to see how do we ensure that some of this work can actually be replicated in other geographies. So we would love to hear any thoughts or suggestions, but would definitely encourage that. Thanks, Michelle.
Let me ask this question to Sunil Babu, and that is, research shows that healthcare depends on support from international organizations, healthcare in Bihar. How do you sell the programs to village leaders to come on board with educating all castes of women in the respective villages? This is from Don Worsfold.
Yeah, Ambassador, I was just responding to that, was trying to type a response to that particular question actually when you turned it to me. Very interesting question actually, because when Gates Foundation prioritized this particular state, the kind of research they did and the kind of information that has been available for us here is like overall in India level as well as in Bihar, resources from development organizations, international agencies that come into public health spending is less than 2% of what the government actually spends by itself. And overall health spends, public spending is not even 10% of the overall spend. So maximum amount is being spent by private individuals, households, and much of it is out of pocket expenditure. And a lot of private sector, as well as qualified private providers, are the ones who are providing majority services in Bihar. and people are accessing most of the curative health services from them. Much of the preventive health services is what the public system is providing, and that needs to be strengthened. And some of the work that people like us and the other development agencies bring in here is more towards sharpening that the preventive healthcare system. And government is uh, open to such developmental interventions to leverage the large resources that they are investing, and the kind of caste system that exists in the communities that prevails, and the gender disparities and all, they prevail. At the same time, there is a substantial progress in terms of individual healthcare seeking behaviors. Like for example, like for any child health, neonatal healthcare seeking, immediately like people go to private sector and take use their own money to take care of it. And there are a number of initiatives by the government of India also to create to reduce the out-of-pocket expenditure for the poorest of the poor. So there are those government-sponsored insurance schemes which have come in, and people are getting benefits out of it. It's a journey to improve that.
A great question from Mary Mendoza, who asks about vaccines. I mean, we're having problems in the United States with people who refuse to take vaccines. Is that an issue in Bihar state where people don't want vaccines?
No, it's not there. Reluctance to take vaccines is not widely prevalent. It's still a matter of reach to the last few who are often getting left out because they are in isolated pockets or constantly on migration. But still, like we have reached almost 80% coverage of full immunization in the state of Bihar. It used to be much lower in the beginning of this particular decade, but like 2005-6, it was around 20% coverage, and then it increased to almost 70% by say 2012, and now it is around 80%. State is trying to push it to more than 90, and it is very hard right now because it's a very few left out pockets who have to be tracked consistently, etc. So acceptance of immunization is not a major issue that we are facing.
This question is from me, and I'm not sure whom to address it to, so I'm just going to throw it up there. And that is, Bihar is a state that sends hundreds of thousands of migrant workers across India, many of whom have returned home because of COVID. How has that complicated the provision of healthcare in the state of Bihar? And particularly, how are you dealing with COVID in the state of Bihar? And I'm not sure whom to address that to.
Yeah, I have been involved in this particular work throughout this COVID period. Among the panelists, at least I was involved, so maybe I could pitch in a little bit of a response. When this migrants returning home phenomenon happened, it was really challenging, and that was a period when we were still not clear about like the state was figuring out how many days to be quarantined, and there were changing guidelines all the time from all the levels. So a proper, like, immediate response, quick response was made, and constantly evolving response. Actually, it happened. Initially, they were all quarantined at a say at a block level, which is like 200,000 population is one block kinds, 200 to 50,000. So there they were quarantined. They were supposed to be quarantined for 14 days, and they were being fed by the government staff themselves. But they always wanted to go home. They have come so far, and now they have to go home. So there is that very difficulty to manage them being there itself. But still, that was tried for some time. Then larger and larger number of people started coming once the trains started operating. So then the quarantine at the community level, home quarantine was ultimately provided, and relatively strict enforcement of the home quarantine was done through frontline workers and the elected local leaders, etc. And there was a tracking for the people who have come back, initially from international travelers, then domestic travelers, like for first 14 days, keep track them. If they have any symptoms, take them for testing. If no symptoms, then keep ensuring that they are at quarantine. So that kind of responses, it kept evolving. And parallelly, the state was also creating COVID care centers. That is where if somebody is positive, you have to you have to come and isolate yourself in the facility, not at home. That continued for some months. A lot of the people who were tested during that migration period were asymptomatic positives. None of them were positive, and keeping them in isolation was becoming a challenge, because they were active adults. Migrants are all young adults who are active and they want to go home, they want to be all around, but we are forcing them to be in isolation. So then over a period of time, how to just segregate symptomatic positives, contact tracing of all the positives, and isolating them, if at all, if they are positive, all those contacts who were traced. So this was an evolving process, and now we are in a situation where a fairly established system of testing large number of people, symptomatics as well as asymptomatics, home isolation, and then if anybody who has any serious symptoms requiring attention, quickly move to a large number of facilities that have been created, where oxygen is the first line of availability of oxygen, and then higher level of care, intensive care, a number of facilities have been created. Testing is something that has been focused consistently, and right now we are at a very large number of tests are being conducted every day. It's managed quite well by the government bureaucrats and the technocrats.
There's a question I saw that now I can't find, and Michelle, maybe this should go to you, or I'm not sure whom, and that is, what is the lesson from health innovation in Bihar State that you would share with the incoming Biden administration of the United States that could help them direct programs through the United States Agency for International Development and others?
That's a great question. And I would say that the first, big lesson is just that we have a lot to learn from the rest of the world, and that we should be mindful of that, and that and in a ways that I think that we are not always. I think we also have actually quite a lot to learn from the way that some of the health systems that are much less resourced than our own have responded to COVID. And I would encourage us to take those lessons, for whether they be from Bihar, or we were just talking to the health minister of Ethiopia. And the third thing I would say is that I think this multi-sectoral approach, in which you really are, Dr. George is emblematic of the kind of partnership that CARE has, that also Pronto has. So again, that there are the necessity of different players coming together. And then I would say, finally, that this idea of community health workers is so important to the work in Bihar is something that I think the US could learn a lot from, in terms of how we engage and deploy. And then I would say the use of technology and data as a tool, because I think that every health system, including our own, is still has some opportunity on the upside there.
Michelle, I want to thank you. And this has just been a tremendous program. We're coming to the end of the hour. And so I'm going to apologize. We didn't get as many questions in as I'd hoped we would be able to. But what Bihar State has been able to achieve in terms of reducing infant mortality and improving maternal health is just extraordinary. And it sounds like you're doing a great job with dealing with this COVID epidemic that we've all been, certainly in this country, been stumbling around with. So I want to thank you, Michelle Nunn. I want to thank Madhu Deshmukh in CARE USA, Sunil Babu, Dr. Casey George, and Dr. Seema Handu. I want to thank you, congratulate you on what you have achieved. I've got to do a little advertisement for ourselves, and that is on Tuesday, November 24th, we've got a program on overlooked America Building Jobs and Tech Skills with former Secretary of Commerce Carlos Gutierrez. It should be a terrific program on workforce development and matching workers and jobs. On December 1st, we've got a program on the US-Japan alliance under President Biden, President-elect Biden, with Shinsuke Sugiyama, who's the ambassador of Japan to the United States. I encourage everybody who's in the US listening to this Zoom conference to please support your local World Affairs Council. That's how we put on programs like this. And I want to give a special thanks to Bill Clifford and Liz Brailsford from the World Affairs Councils of America, to Mariela Rodriguez from CARE USA, who's been really helpful pulling this together, Tony Lemieux from the Atlanta Global Studies Center, Fernanda Lucchine, our executive director at the World Affairs Council, and Valerie Lopez DeFrank, who is the producer of this show. I will hope to see you all, including those of you in India, on November 24th at noon Eastern time. And I want to thank you all. Michelle, this has been great. Thank you so much.
Thank you. And thanks to our terrific panelists for their leadership and their work and their example.
And thank you for our continued collaboration between CARE USA and the World Affairs Council.
And congratulations for being one of the winners of the national award.
And we're all going to not sing happy birthday to you.
Yeah.
Okay.
Thanks, everybody.
Bye, everyone. Thank you so much for
Thank
attending.
you.